Aloha, I'm Dr. Trevor. So today we are going to talk about malnutrition. So the first thing is always suspect every children for malnutrition. So we always screen for malnutrition by using MUAC, mid upper arm circumference, and we need to check the age, the sex, the height, and the weight of the children. So first, does the child have any of those features? The first thing is severe wasting, which is also called marasmus. So the patient will present with old person's face, irritable, visible wasting, especially the upper arms, the buttock, and the ribs, and also low body weight. And the other type of malnutrition is kwashiorkor, which the patient will present with apathy and edema of legs, arms, face, and some skin rash, and hepatomegaly. So how do we screen for malnutrition? So to be diagnosed with SAM, the child must have severe wasting. So the first thing is the mid upper arm circumference less than 11.5 centimeter, or weight for height, weight for length less than -3 standard deviation. And the other type is kwashiorkor with edema of both feet. As you can see in the right side, that is the MUAC, mid upper arm circumference. So we use this tape to measure the circumference in the middle of the upper arm. So this is the threshold for severe acute malnutrition. For infant less than 2 to 5 months, it's less than 11 centimeter. For children 6 months to 5 years old, is less than 11.5 centimeter. And moderate acute malnutrition is 11.5 to 12.4 centimeter. So if the MUAC is 12.5 to 13.5, the patient is at risk for malnutrition. So how about the concept of weight for height and weight for length? We know sometimes when the patient is having malnutrition, instead of being slim, the patient cannot grow very tall. So that's why we need to screen for weight for height, is because there are some patients who is stunning, they cannot grow in their length and they cannot grow in their height. So the first thing you look at the table is it boy? Is the patient boy or girl? And then the second question is, how tall is the patient? So as you can see, let's say the patient is 60 centimeter. So you can see the median body weight for patient for a 60 centimeter girl should be 5.9 kilogram. If the patient's body weight is 5.3, which is less than -1 standard deviation, less than 5.4, she is at risk of malnutrition. But the definition for moderate acute malnutrition is the body weight less than -2 standard deviation. So in a 60-year-old girl, less than 2 standard deviation, let's say 4.8 kilogram, less than 4.9, is having moderate acute malnutrition. And if the body weight continues to decrease, for a 60-year-old girl, let's say the body weight is 4.4, which is less than -3 standard deviation, less than 4.5, 4.4 kilogram for a 60 centimeter girl is having severe acute malnutrition. So as you can see, the definition for severe, moderate, and at risk malnutrition. So less than -3 standard deviation is having severe acute malnutrition. -3 to -2 is having moderate acute malnutrition, and -2 to -1, the patient is at risk for malnutrition. And then we talk about edema of both feet. So how do we screen for this? So the pitting edema is usually most obvious in the feet. So when pressure is applied for a few seconds on the feet, a pit remains after the finger is removed. This is what we call pitting edema. And how do we grade the extent of edema? It's commonly rated in the following way. So 1+ is having mild edema of both feet, but 2+ means that the edema has extend to lower legs, hands, and lower arms. But if the edema extend to the hands, to the arms, and to the face, this is having severe edema and will grade with 3+. So the next question is, does the patient need treatment? So the first thing is to consider whether this patient is having complicated SAM or uncomplicated SAM. So what do we mean by complicated SAM? As you can see, complicated SAM is SAM, severe acute malnutrition, with a medical complication, or SAM with no appetite. So in this case, you can see for patients with SAM, if the patient is less than 6 months old and the patient is having serious breastfeeding difficulties, and this is also actually a medical complication. For age 6 months and older, so MIWAC less than 11.5, weight height less than -3 cm, with the medical complication of anorexia, vomiting, convulsion, lethargy, loss of consciousness, hypoglycemia, high fever, hypothermia, dehydration, pneumonia, severe anemia, vitamin A deficiency, and skin lesion. These are all the medical complications. So if they have medical complication in SAM patient, so it's called, if they have medical complication in SAM patient, it's called complicated SAM. And this kind of patient, we need to be admitted for inpatient care. And the second thing is SAM with no appetite. So we used to use bumpy nut to screen for appetite. However, because in Sierra Leone, Nixon Hospital, we don't have bumpy nut. So actually we can use the ground up paste and mix it with sugar and some water and let the patients try it to check, to screen for his appetite. So if the patient is not eating or eating poorly, appetite is not good. So this is also called complicated SAM because the patient is SAM with no appetite. So let's say the SAM patient has no medical complication and is eating with appetite, then the patient is not complicated SAM and is called uncomplicated SAM. So SAM with no medical complication, SAM but the patient has appetite. So this kind of patient we can manage as outpatient, and we can consider oral antibiotic with amoxicillin for 5 days. And the patient should be started on ready-to-use therapeutic food, RUTF, which is bumpy nut. And since we don't have it in Nixon Hospital, so we can use Benamix or Picimix instead. So we must also screen for HIV and TB tuberculosis in this kind of patient. So this is the parameter we use for the appetite test ideally. So let's say if the same patient is having medical complication and or no appetite, so this kind of patient need to be admitted for inpatient treatment. So first thing, don't forget your ABCD assessment, and then treat hypoglycemia, and then keep the patient warm because hypothermia is associated with low sugar and infection. If the patient has diarrhea, give Rizoma, rehydration solution of malnutrition. And then IV injection antibiotic, first line is ampicillin plus gentamicin. And then start IV antibiotics for 2 days, then reassessment, and consider switching to oral amoxicillin. And then screen for HIV and tuberculosis. And then start F75 in step 2 or as soon as available, and alternate with Rizoma, rehydration solution for malnutrition. So the treatment for malnutrition is separated into 3 different phases. So for the first 2 days is what we call stabilization phase. So in the first 2 days, it's very easy to get hypoglycemia, hypothermia, and dehydration. So remember, in the first 2 days, we need to screen for hypoglycemia and test for sugar, and then keep the patient warm to prevent hypothermia and rehydration. Of course, we also need to continue with other treatment for electrolytes, and then infection, micronutrients, cautious feeding in the first week. So after the first 2 days of the stabilization, after that is what we call transition phase. It's day 3 to day 7. And then after that, starting from second week, is what we call rehabilitation phase. So as you can see, so for the micronutrients in the first week, ideally we don't want to add iron because iron might affect the immune system. We add iron in the second week. So in the first week is with the cautious feeding, and then the second week is the catch-up growth. Throughout the stabilization, transition, and rehabilitation phase, we should provide necessary stimulation. And then after the stabilization and transition phase, we can start preparing for follow-up in the second week during the rehabilitation phase. So the first thing is to prevent hypoglycemia. We need to test for sugar and give dextrose 10%. So if the blood sugar level is less than 3 millimole per liter, we need to treat with 5 mils per kilogram of IV dextrose. However, in neonates who is less than 1 month, we need to treat if the blood sugar level is less than 2.2 millimole per liter with 2 mils per kilogram of dextrose 10%. And how do we prepare dextrose 10%? We use dextrose 50% and dextrose 5% with the ratio of 1 to 9. So 1 mils of dextrose 50% with 9 mils of dextrose 5% to make it become 10 mils of dextrose 10%. If you want to make 100 mils of dextrose 10%, you add 10 mils of dextrose 50% with 90 mils of dextrose 5%. So of course, you can also use dextrose 10% from dextrose 50% and sterile water, injection water, not just any drinking water, because you want to inject into the blood vessel is injection. So if you want to use dextrose 50% with sterile injection water, use the ratio of 1 to 4. So add 1 ml of textured 50% to 4 ml of sterile water. So the second thing is to prevent hypothermia, especially there's a concept of kangaroo parents care in the preterm child. So you will carry the preterm baby over on your chest, and then to keep them warm. So this is to prevent hypothermia. And then the third thing is to prevent dehydration. So remember we say that in severe acute malnutrition patient, oral rehydration solution is not suitable for them because the sodium level is too high. Instead, we use Rizoma rehydration solution for malnutrition because the sodium is lower. And then it's common to have electrolyte imbalance. So we need to encourage the patients to eat more banana and avocado, and then treat infection with antibiotics. So after that, we need to cautious feeding with F75 milk. So for the first 2 days is what we call stabilization phase. We use F75 to feed the children with the frequency of 2 hours. So every 2 hours, the patient should get feeding. And the amount of F75 is different for patients with severe edema or without severe edema. So let's focus on the children without severe edema. So the volume per kilogram per day is 100 ml per kilogram per day. So after that, starting from the third day, we will switch to F100, but the frequency will decrease to every 3 hours. But the volume of F75 is still the same. It's 130 ml per kilogram per day. And then starting from day 6, we can decrease the frequency to every 4 hours. But the volume per kilogram per day is still 130 ml per kilogram per day. And if ready to use therapeutic food is available, which is pumpkin nut, if pumpkin nut is available, we can also use pumpkin nut. So the problem is actually in some places we don't have F75 or F400. So instead of using the proper F75 and F400, we need to use alternative milk ingredient using whole dry milk. And it depends on which type of milk you have. If you have dry skim milk, if you have dry whole milk, or if you have fresh cow milk, in the ingredients and the recipe will be different. And this is the type of F75 recipe we use in our hospital. And this is the F100 recipe. However, for patient who is younger or equals to 6 months, because they cannot tolerate the F75 and F100, so we can use a recipe called diluted F100. So this diluted F100, we start with 160 ml per kilogram per day. 160 ml per kilogram per day. If the patient is stable and tolerating, you can gradually titrate diluted F100 up to 320 ml per kilogram per day. 330 ml per kilogram per day. So once the patient is gaining weight for 3 consecutive days, very regularly replace the diluted F100 with normal breast milk substitute. And then to titrate from 120 kilo, and this is the pumping nut ready to use therapeutic food if it's available. However, if it's not available, we can use LMICs. And actually, there's another recipe called picky mix is even more suitable for malnutrition patient. So for complicated we cautious feeding with F75 and then F100 and then catch up growth with F100. We need to check the body weight every day to see whether the patient's body weight is increasing. If the patient is not gaining weight, less than 5 grams per kilogram per day, we need to reassess FP test for RBS, and is the patient having tuberculosis? And then if the body weight increase is moderate, to check whether the intake targets are being met. Have they finished the milk? Or maybe is the patient still having vomiting or diarrhea? And if the body weight is increasing more than 10 grams per kilogram per day, the body weight is increasing very well. So you might consider discharge the patient. And then the next thing we need to talk about is the macronutrients. So if there's corneal ulcer, we can add vitamin A. And then for folic acid, the first thing we need to give 5 milligrams of folic acid and then continues with 1 milligram daily. And then we need to add multivitamin syrup, zinc, copper. But remember, in the first week, we don't add iron. We add iron in the second week. And then we can also stimulate the sensory by providing tender loving care and a cheerful, stimulating environment, structured play therapy for 15 to 30 minutes per day, physical activity. So support for as much maternal involvement as possible, comforting, feeding, bathing, playing, and provide suitable toys and play activities for the child. So we can also play music for the children. So these are the criteria, discharge criteria. So less than 6 months, less than or equals to 6 months, all clinical condition or medical complication, including edema, are resolved, and the child is clinically well and alert. The child is breastfeeding effectively or feeding well, and the weight gain is satisfactory, which is more than 5 grams per kilogram per day for at least 3 consecutive days. So for some patients more than 6 months, we need to make sure they have completed IV antibiotic treatment and clinically well and alert, medical complications are resolved, appetite has fully recovered, and they are eating well, and edema has reduced or resolved. So these are the supplements you can read for malnutrition. Thank you. Bye, Kaka.